Hello doctors, let me read the question for you. There is a chest x-ray which was recorded from a patient presenting to emergency with the complaints of breathlessness. What is the most likely diagnosis? So the examiner is trying to test the basics of reading a chest x-ray. Okay, before going into the options, let me tell you there are basic steps A, B, C, D, E, F, G, H, I. This is the mnemonic, that is the basic steps to read a chest x-ray. A is about airway and introduction. B is about the bony part. C is about the cardiac size. D refers to the diaphragm. E part refers to any effusion. F is about any presence of foreign body. G refers to the gastric bubble. H is about hyla and mediastinum, and I is impression. So let me apply these basic steps for this given chest x-ray. You can clearly see the airway is straight, there is no tracheal shift, and B, the bony part is normal, okay, and the cardiac size, there is no cardiomegaly. And next is D, look at the diaphragm, left side is below the right, and you can see a gastric bubble here, fine, and the left costo-diaphragmatic recess is free, so there is no fluid here. But when you look at the right side, you can clearly see there is an opacity in the right costophrenic angle. Along with that, you can clearly see a fluid level, a horizontal fluid level here. So you can see air here followed by a fluid. So the first abnormal finding from this chest x-ray is air fluid level. So this is a clue for us. Next is the remaining parts. Yes, there is an effusion here. F is about any foreign body. There is no foreign body in this. And G is about the great vessels and gastric bubble. They are present. And H is about hilum and mediastinum. You can clearly see there is no mediastinal lymphadenopathy in this given chest x-ray. And the final impression depends upon the differential diagnosis of air fluid level. So 5 important diseases present with air fluid level on chest x-ray. Okay. First one is very own hydropneumothorax, which is important for exam point of view. And the option here is hydropneumothorax. The other 4 are pyoneumothorax, the same fluid, there is pus formation. The third is pulmonary abscess, and fourth is any soft tissue abscess above the lung level, and the fifth option is traumatic pneumatococcus. So try to remember this differential diagnosis. So from the given 5 differential diagnoses, only one is there in the option, and that is hydropneumothorax. The X-ray here is showing air fluid level. So mostly the diagnosis is hydropneumothorax. Let us learn few important points about hydropneumothorax. What is hydropneumothorax? It is the presence of both air and fluid inside the pleural space. Okay, where it is present? It is present inside the pleural space which is surrounding the lung. And what are the different causes of hydropneumothorax? Number 1, the most important cause is iatrogenic, they say. Okay, iatrogenic is the most common cause. That is because of introduction of air during the pleural fluid aspiration in the clinics. Okay, and the next is the presence of gas forming organisms in the infection can lead to the formation of air in the pus. And number 3 is thoracic trauma. And the fourth cause is very important, bronchopleural fistula. This can lead to hydropneumothorax. So what are the different signs? This is important part of discussion. There are 4 signs and the mnemonic is 4S. First is straight line dullness. So the first S is straight line dullness. The second S is shifting dullness. This is important because shifting dullness is usually seen in ascites, right? So the similar sort of shifting dullness is also seen in hydropneumothorax. The third S is succussion splash. Okay, the third S is succussion splash, and the fourth part of S is sound of a coin. Okay, sound of a coin. Let us look into the details of these 4 signs. Starting with first sign, straight line dullness. So on percussion of the patient, because of the presence of fluid, you can clearly elicit a straight line dullness during clinical examination. So the second part, very important, is shifting dullness. How to examine the shifting dullness? As we all know, when there is air and fluid, the fluid part shifts easily to a dependent position, right? Okay, like let us say the patient is in a decubitus position, okay, and this right side part is the diseased part, and because of this position, right lateral decubitus position, there is fluid collected on the dependent position, and you can clearly see the air is above. So in this position, the dullness is here, point A. And when the patient is in erect position, now the fluid is here, and now there is dullness in the previous resonant part. So there is, you can clearly see there is a shifting dullness similar to the ascites in this case. The third sign is succussion splash. What is this? Make the patient sit, percuss the upper limit of dullness, okay, and on the dullness, place the stethoscope and hold it firmly just above the upper limit of dullness. Okay, now hug the patient, shake him, move along with him. When you do that, you will clearly hear a splash which is similar to the splash that can be heard over stomach containing air and fluid. Okay, so this is succussion splash. And fourth sign is sound of a coin. So how to elicit sound of a coin? Just concentrate here. In this coin test, we take a coin and we put it against the chest, okay, and we have to tap this coin within another coin, and on the back side of the percussion, or on the back side of a topping of a coin, we have to place the stethoscope and we have to listen to the sound. Okay, we have to listen to the breath sounds and also the sound of the coins. Okay, in case of hydropneumothorax, you can clearly hear a tinkling sound. Okay, you can clearly hear a tinkling sound. So this is coin test positive, and the sound of coin is indicative of hydropneumothorax.